face of Dr. Tolulope Olabintan of Livingspring Family Medical Center here in Mansfield, Texas. I am so happy to be here. Today, we'll be talking fibromyalgia. For those of you who don't know, you'll find out what that is once we get our guest on. And one of the things I like to do real quickly is just talk about why we decided to talk about this topic. So fibromyalgia is is growing in incidence, meaning number of patients that have fibromyalgia or diagnosed with fibromyalgia. And so I've had a few requests to actually have this done. And our guest is here. I'm so excited. Awesome. I'm going to bring her on. She's an expert. Why we tend to have these lives. So if you have topics that you wanted to have discussed, I always like to have guest doctors come on and we discuss from a specialist perspective. Thank you so much, Dr. Martina, for coming on here. We're so excited. We're stoked to have you here discussing fibromyalgia.
Thank you for having me, Dr. Tolu. I'm really very happy to be here, and I appreciate the opportunity.
All right, not a problem. So we're going to go right to it. And I typically like to ask, you to please, can you kindly introduce yourself to our viewers? Who are you and what do you do?
Yes, thank you. So my name is Martina Ziegenbein. I'm a rheumatologist. I have been practicing for 14 years. I have recently moved from Wisconsin to Cape Cod about 7 months ago, and I work for Cape Cod Healthcare.
Okay. Awesome. So thank you for being here. Now, the next question is this. We're curious. Rheumatology, why do you do what you do? Is there a story behind it? Why did you decide to be a rheumatologist? And particularly, why did you decide to do something when it comes to fibromyalgia?
Thank you for the question. So in terms of why rheumatology, when I came to America first in 2001 to do the residency, I was initially going to be a cardiologist, or I was thinking about cardiology, but then I met my mentor, who was a rheumatologist. It was the first month of residency, and he came to give a talk to residents about rheumatology, like just the general core lectures for residents. And he opened up the talk he asked, you have a patient who complains to you about pain. What do you do? And there were some responses, oh, you order this and this test. And he says, no, you talk to them and you examine them. And I'm like, I want to be like him. So that's why I decided to be a rheumatologist. And then as far as fibromyalgia, I have to admit to you, I was not always an enthusiast, because caring for fibromyalgia patients can be very exhausting if you don't have the right attitude. But I have always gravitated towards it. And then when I moved here in March, it has been at the back of my mind, because patients, especially women, respond well to me when I ask them questions. And I finally decided I'm going to embrace my interest in pain. And even though I don't know everything, I decided I'm going to help them. So I started taking on more and more fibromyalgia patients. And my plan is to eventually open a fibromyalgia center on the East Coast. So it's actually a very fascinating area, fibromyalgia pain.
Awesome. And you highlighted a few things, about the attitude with taking care of patients, really empathizing with them and having a good attitude in caring for them and validating that their symptoms are important, they're valid, and you want to help them feel better and not just dismiss it. And we'll talk more about that as we go along. So for those who are watching who may not know, what is fibromyalgia?
Right. So yes, we'll start with the basic question. So there are many definitions depending on where you look, but the easiest or the simplest definition is that fibromyalgia means patients have pain all over, and they can have associated symptoms. They can have poor sleep, fatigue, difficulty concentrating. They can have IBS symptoms, irritable bowel syndrome, or TMJ, and pain in other areas. The most overwhelming is the pain, fatigue, and difficulty concentrating. And it can really sometimes it can derail their lives. They are not able to work full time, or they are so exhausted they cannot play with their children or take care of their family. So it can be very debilitating. And the new research, and so what I would like to point out is that there have been quite a bit of research done, and it confirms that the pain is real. That has been one of the biggest why fibromyalgia has gotten bad rep with public in the past, because patients felt that providers who listened to them or who examined them, they were telling them that the pain is in their head. And we know that that's not true. We know the pain is real. And I was going to point out one particular. It was discovered more than 20 years ago by Dr. Claw, who is the pain researcher at University of Michigan. They did functional MRIs of brain of people with fibromyalgia, and they were able to prove when they stimulated these patients or they applied pressure on different areas of the body, their functional MRIs lit up in the centers corresponding to the area that had applied pressure. So we know the pain is real.
And that's validated.
Yes.
Just acknowledging that the pain is real, and letting the patients know that you understand that it's real is in itself one of the steps towards recovery, or at least feeling better. So that's key. Thank you for sharing that data. So for those who are wondering, what causes it?
Yes, excellent question. You have such good questions. I really appreciate that. So short answer is nobody knows 100% sure. However, the current theory is that the pain is a result of misfiring neurons that are misinterpreting the information from the periphery of the body as dangerous, and actually the brain is causing the pain. So it's the misfiring neurons that are causing the pain, and that's why the pain is referred to as neuroplastic, not neuropathic, but neuroplastic pain. And it means a bunch of misfiring neurons that are interpreting information from the body, from the receptors in the body as dangerous, and danger signal increases cortisol levels and can produce pain. And in terms of why it happens, so again, there are many theories, but the current kind of leading school of thought is that many people with chronic pain are sensitized to it in childhood. It's referred to as adverse childhood experiences, when they can experience any trauma. It doesn't have to be physical abuse, but any type of exposure that makes them feel unsafe. It can be just patients, parents who were too critical or who were yelling at them. It could have been emotional trauma or sexual or physical, and that kind of sensitizes their brain. And then as they grow up and they start experiencing other hits, so to speak, when they are exposed to more trauma or more stressful events, it kind of then starts accessing that danger signal that might have been created in the childhood, and that starts the vicious cycle of creating pain. I read I'm part of the pain course right now by Dr. Schubiner, who is another leading physician in terms of pain management. And basically he believes that, and not just he, there were studies showing that our memories are stored in our prefrontal cortex, and that is very closely connected to pain brain centers. So when we are triggered by something, whether it's a stressful event that is positive or negative or positive, some people start experiencing pain after positive, like after birth of their children or after wedding. Anything that triggers this brain network that is connected to pain centers can start the cycle of pain. And then I was going to say, then it's believed that some personal characteristics, people who are very self-critical or who put high expectations or pressure on them, or those who are caregivers and they put others in front of their own care, they are also at high risk of experiencing chronic pain.
Oh, wow. You said a lot.
Oh.
You unpacked a lot.
I'm sorry.
No, that's good. So one of the things you did highlight, like, we're not entirely sure. So these are data that's still being processed, that's still being collected, collated. So of course, this doesn't apply to everyone. So I just wanted to say that, but talked about possible relation to things that happened in childhood, where the brain is sensitized due to certain traumatic experiences. Stressful triggers are also one. And then you also talked about certain personality types. Not all. It's just it's associated, right? Yes. With people who are very self-critical, and people who do not prioritize their own health. Right. It sounds like.
Or, who do not prioritize their own health as a result of caring others and putting other people's needs in front of theirs. They are as I said, it was kind of the observational studies that seem to suggest that they may be at higher risk. But I was going to say there are some studies that show that genetics play a role, that if parents or a parent had fibromyalgia, that the offspring is more likely to develop. But the correlation, I'm not able to say like that. I'm not sure how the percentage works out here.
Okay. All right. And this kind of segues into our next question of how can one prevent it? Is that even possible?
To prevent it from happening. So I don't know that studies actually have been done because all of us carry some trauma, but I don't think I can answer that question fully because I'm not sure. I'm not familiar with the research, because you would have to know, I guess I wonder if it's even possible if you had twins or siblings, one of them developed fibromyalgia and the other don't. I think I'm not familiar with the data. I'm sorry.
Okay. Oh, no, that's good. It's because some people will be asking, well, what can I do to make sure I don't have it? Well, we don't know. It's still being studied. And so there's grace for it. Hi, Dr. Una. Nice to see you.
Dr. Una.
She's watching. Yes. All right. So that brings me to our next question. Fibromyalgia is, to say the least, something that can be debilitating, can affect quality of life, can affect outlook of life, can affect a lot of things. And I've seen that in my patients. And of course, as you have, how can one cope with it? And I want to kind of divide this into two different ways, because there's the good days and there's the bad days, right? So before we go into the good days and the bad day type distinction, how do you advise your patients? Of course, outside of medications, seeing your specialist, see your primary care doctor, needing that referral, following up with your appointments, and medications, of course. How do you tend to advise your patients? How can they cope with it? And that's a heavy question.
Yes, yeah. So I'll take a few moments, or I'll take a few steps to answer, if I may. So it's a very good question, because that's at the heart of what we do. I think first is the education. Basically, every patient that I diagnose with fibromyalgia, or who comes with a diagnosis, but I'm asked to opine, I first confirm that he truly or she does have fibromyalgia. And that is a combination of exam and making sure that the labs are normal. So first is to confirm the diagnosis. Second is education. Education about fibromyalgia being neuroplastic pain is truly the key, because many patients, when I explain to them what a neuroplastic pain is, many of them actually have like a aha moment, and they said, that makes complete sense, like that. And they even tell me, well, I do have a tremendous stress in my life, or this is what happens. And many of them tell me they feel better just by explaining things. They did not connect their stress. I had one patient recently, she's incredibly worried about her husband, and she started experiencing these weird pains that she was not at all correlating to how worried she is about her husband. And when I explained to her that, yes, this is what any danger signal that our brain registers and stores in our memory, that can translate eventually, if it's too much, it can translate into pain. Pain is basically a message from the brain. So so education is number one. Number two is then what we do is so there is a term referred to as pain reprocessing therapy. That's what I'm implementing in my practice. And it consists of basically approaching pain with curiosity rather than fear or trying to fix it or escape from it. So we do something that is called somatic tracking. We can talk about it maybe a little bit later. And then the next piece is managing all associated conditions. So managing stress, managing sleep, managing anxiety and depression. Many of my patients do have diagnosis of depression or depression anxiety, and they need to be on medication. So it's extremely important to address. And then I really truly believe, and studies have shown that it's important, mindfulness as a means of managing stress, but also fierce self-compassion. And again, we can talk about that. So I didn't quite answer the question about how I divided between good and bad days. So let me talk about that. I think what one of the main things that we tell patients about a good days, don't overdo it. So pace yourself so that you don't bring on the flare of fibromyalgia. And on a bad day, we encourage avoidant behavior. So I'm not talking about not getting out of bed. We still want people to try to do as much as they can for their normal life. But we do say, on a bad day, when you truly are struggling with a lot of pain, do anything that you can soothe yourself, your body, towards feeling better.
Wow. Okay. So you unpacked a lot.
Okay. So I guess you have to stop me then.
No. That's good. But I want to break it down some. You said very important things about how you tell patients, or how you encourage people who are who have fibromyalgia to cope. Number one, confirming the diagnosis. And we didn't talk about that. I think I skipped that question. And that's usually confirmed by a good physical exam, and then certain blood tests that turn out negative, meaning they're normal. Right. So it's almost like a diagnosis of exclusion, meaning we make sure it's not this, we make sure it's not that. And so that's why it's important to see your doctor, have that conversation, have blood tests, and then do the physical exam. And then if it's not that, you see the specialist, you have the confirmation test too. So confirming the diagnosis is one. And then number two, educating about the neuroplastic pain, breakdown of fibromyalgia, explaining and validating their pain. Very, very important, because that's something that's, when it's dismissed, it actually makes one feel worse, because you feel like, oh my gosh, is it in my head? It's not. And you said something, you said pain is a message from the brain. Correct. If something's awry, like something is off, or something is wrong, or something needs to be addressed, or something needs to be paid attention to. And then you said it's very important, the pain reprocessing therapy, where you treat pain not as something to be feared, but as a curiosity, right? Okay, so what is my body trying to tell me, right? What is my body trying to communicate to me? And that is key. I love that. The next thing you mentioned is the importance of managing things that come alongside fibromyalgia. And I see that quite a bit: anxiety, depression, poor sleep, and stress management. That can worsen it. So it's really important to manage stress, make sure you get enough sleep, make sure anxiety and depression is also addressed. And you also mentioned mindfulness and self-compassion. Love others as you love yourself. There's a balance to both. That's one of my favorite scriptures, and it talks about the balance of both. Love others as you love yourself. So self-compassion. And then you went to the next question. You answered the question of how do we encourage our patients during their good days, and then how do we encourage them to their bad days? And for the good days, you said pace yourself. And I see this quite a bit. Good days, oh my goodness, let me catch up on all the work I haven't done, right? I got to do this. I'm having a good day. Let me make the most of it. But one has to be careful to balance that and not overdo it. And then on the bad days, avoid avoidant behavior, right? So, you want to stay in the bed.
Right.
You want to stay in bed all.
So we try to encourage to do, at least minimum, meaning doing what they need to, but basically maybe not cleaning their house or not, like sometimes not everything needs to be done. And I actually do see it a lot. I recently had a young patient who, her husband came with her to the appointment, and this was her second visit. He came for the first visit too, and we were talking about how she needs to prioritize herself and her well-being, and she looked at me and then at him. She didn't know how to say it, so he spoke, well, there are some things like that need to be done, like you take care of your son. And I'm like, so basically it was coming from him that he was expecting her to do certain things. I think there was a cultural part to it too, a little bit. I think they're from India, and I said, yes, I do take care of my son, and we have to get out of the door every morning for me to go to work, and he goes to daycare. I said, but not every day the dishes are done, or, some days our bed is not done, or some weekends I don't do full laundry. I was trying to explain to her how, like, things are not written in the stone. If she doesn't feel well, that the world will not end when she doesn't do everything that she's, quote, supposed to do. And that was a completely novel idea to her. And I don't know what they had discussed after, but I had a very strong feeling that she's influenced by her husband. And this is not I want to make it clear, I'm not trying to make wives not be good wives, but I'm trying to stress how important it is to listen to our bodies and to ourselves. And we are not robots, and we first should listen to our bodies and only then to the duties. And obviously some things need to be done, like our children need to be fed, and but sometimes it's okay to have pizza, that you put in the oven, how to say it, frozen pizza, and you don't have to cook 3-course meal every night, So I guess I was meaning that way, that you avoidant behavior and do whatever you need to take care of your body in order to feel better.
Right. And it's putting the first things first, because if you were to collapse or break down, those things will suffer anyway. And so there's a balance to that. And I like that, he came in on the visit too, because I think one of the things that's very important in caring for someone who has fibromyalgia is getting the family involved, and also involved in the understanding of the disease process, and also empowering them to be able to assist and to help them to understand that the days where it might hurt a little bit more. And so we don't encourage them to stay in bed all day, but at least kind of get up and try to do the absolutes, because that's important. So that balance is very, very important. And it's done routinely, educating the patient, educating their family members, and answering questions about, well, what are ways I can still thrive and do everything I need to do with this, and I agree with you, even for those who do not have fibromyalgia, there's sometimes it's okay to leave the dishes if it gives you a little more peace of mind just for that day.
Absolutely.
Okay. I used to not be able to sleep without the dishes being done.
Oh, wow. You personally?
Yeah. It bothered me, like, oh, no dishes, like dishes in the sink was like, oh my, but now I'm like,
it's okay.
Kids are good, fed, hugged, and husband's good. Yeah, it's okay. We're doing it.
There you go.
All right. Now, we've talked about some of this already through the course of our discussion, but how, and this is where it gets a little more, I've had it where patients tell me that this is a sensitive spot for them, because sometimes people cannot relate to how they feel. And so, they look good, skin is rosy, limbs are in place. And so, right, are in place. So, and so sometimes things are suggested like, oh, it may be imaginary, or it's like you said earlier, it's in your head. How do you encourage the patients particularly? And I want you to also speak to those who are family members of
I
those who have
see. I
fibromyalgia.
see.
But
So I would say that they should try to explain the pain, as I mentioned at the beginning, that it's like misfiring neurons in the brain. The pain is real, that the research has shown the pain is real. The brain centers are activated in the brain. And it's not in their head, it's in their brain. They can tell them there is a difference between this being in my head and the pain coming from my brain. The brain is causing the pain. And there are ways, and they can tell I'm working on it, but the pain is real. They should just repeat that the pain is real. And if the family members, I wouldn't quite know why they wouldn't want to believe them, but they can say, you not believing me is cruel. You telling me that it's in my head, that's cruel. And they can bring the family member to the appointment. I always welcome to talk to their family members. And sometimes it's hard to comprehend for some patients are very quick to pick up on the message that the pain is caused by the brain, that there is a danger signal and the brain caused the pain. Sometimes it's hard even for patients to understand. So I understand that their family members might have trouble too, but once the patient accepts the diagnosis, usually they find a way to, explain it to the partner because they feel better about it. Like, my pain is validated, it's real. The doctor told me it's real, and giving them hope then is also important because that's kind of translating to giving hope to family members. As I said, I mostly have patients come alone, but sometimes they come with their husbands, especially younger women. And the older women that I see, it's very sad. Sometimes, one of them recently told me, yeah, I take care of my husband who is in a very bad shape. Like, he's ill. She provides care for him, but he's also kind of bossy and expects her to do things. And she has 2 sons. And I said, you may need to have a discussion with them about the fact that you need time for yourself. And you don't have to take 3 hours every day. It might be just an hour, but you need help. And she was very receptive to that. And when she came back, I asked her, did you have a discussion? She said, yes. And they said, yes, they will do it. But she said, it's kind of a slow process because it's 3 men, 1 woman, and it's just sometimes hard. So.
So I'm glad that those conversations are happening. And, one thing I want to emphasize, we also stressed coping mechanisms. So it's just validating the diagnosis, empathizing with the person who's having the diagnosis and saying, I understand that this pain is real. What can I do to help you with what you're going through? Okay. And how can we thrive even with it? Okay. And that's the purpose of this talk, and I'm so excited that you are actually going to be focusing on this. I do have quite a few patients who have this diagnosis and would like to feel better and would like to have a support system. And I think you offer not just the medical treatment for it, but also that the balance of all the treatment options, including some of the things you mentioned, and pain reprocessing therapy, managing stress and sleep and anxiety and depression, and educating on neuroplastic pain. So I'm really excited for those. I'm excited for those who have it, that these are options for them. So that being said, where can people find you? They're saying, you know what, I want to connect with this doctor. I want to hear more topics on fibromyalgia from her. I would like her to come speak at a local event. Where can they find you?
A very good question. So I think right now the easiest would be to find me on Facebook. If they are they can send me a friend request. I'm in the process of starting a support Facebook group for fibromyalgia patients that I will be managing. So I will be the content creator, and I will be not policing it, but basically making sure that patients get advice, or that it doesn't derail. There are a couple of fibromyalgia groups on Facebook that are just basically patients come there, or women, and report the pain, and it's just like a pity party, but they don't have too many constructive things to say. So I am thinking, so they should just send me a friend request, or they can, and then I can invite them to that Facebook group. And I'm a couple of weeks behind on that in terms of creating it. And then I can type my website. So they can, if they are in Massachusetts, they can contact Cape Cod Healthcare Rheumatology if they want to see me. And if they would prefer to work on one-on-one, they can visit my website, and I can type it in because it's a long name. Would you like me to do that? Or?
All right, so awesome. So I will make sure that we have that information, and also your Facebook information as well. This has been very, very helpful. I'm hoping that those who are watching this, live, and those who are watching the replay are encouraged to know that there's support systems out there. There's support options for you. You can thrive even with fibromyalgia. We are understanding more the nature of the disease process. We understand that it is real, and there's more research coming, and there are ways to thrive even with it. So thank you so much, Dr. Martina, for coming. I am so honored to have you here.
Thank you so much, Dr. Tolulope, for having me.
We may have another one in the future, and I'll let you know.
I would love that.
Okay?
Thank you.
All right, awesome. So for those who are looking in the Mansfield, Texas area for if you or anyone you know is looking for a family doctor who is caring, who is thorough, who's passionate, I am she. Thank you guys for watching. Please share.